Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for this program titled Accounting for the Impact of EGPA on Patient Quality of Life. This program is part of a CMEO snack series supported by an independent educational grant from GlaxoSmithKline. I'm Dr. Michael Wexler, Professor of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine. And I'm the director of the National Jewish Cohen Family Asthma Institute at National Jewish Health in Denver, Colorado. I'm joined today by Dr. Jennifer Gordon. Jen, welcome to our program. Please introduce yourself.
Thanks, Dr. Wexler. I'm Dr. Jen Gordon. I was diagnosed with EGPA in 2014. I'm also a biomedical researcher, and I spent 30 years as an NIH-funded investigator studying neurological disorders and infectious disease. I'm a patient advocate with the Vasculitis Foundation and co-PI of the Vasculitis Patient-Powered Research Network. I serve as a patient partner for the VPPRN's EGPA registry as well. You can follow me on Twitter at Vasculitis, where I tweet out PubMed links for the latest articles on vasculitis for the Med Twitter community. It's great to be here today.
It's great to have you, Jen. So let's dive in and start off by reviewing our objectives for today. Today, we're going to learn how to assess how EGPA and associated conditions can impact patient quality of life. We're going to cover some of the ways in which you can better assess the impact that EGPA has on the lives of your patients. Let's start off with a brief overview of EGPA. EGPA is one of the ANCA-associated vasculitides. ANCA, or anti-neutrophil cytoplasmic antibodies, really represent a subset of patients who have vasculitis. EGPA is a disease that's characterized by asthma, chronic rhinosinusitis, elevated eosinophils in the blood, tissue and organ eosinophilic infiltration, with the potential to cause vasculitis and end organ damage with tissue involvement in a variety of different organ systems, including the heart, the lungs, the blood, the GI tract, the kidneys, and a variety of other organs. It's a relatively rare disease with only about 5,000 patients in the United States. But the key finding is that of blood eosinophilia that causes a lot of the tissue damage. Now, one of the things that we hear from patients is that they frequently experience long delays in finding a diagnosis. In general, there can be as long as 4 years between the symptom onset and diagnosis of disease. One of the problems is that early symptoms are often nonspecific. Weight loss, malaise, fatigue, they may not be recognized as EGPA. And patients may not see a practitioner that's familiar with EGPA until later in their diagnostic journey. In general, one of the problems with this delayed diagnosis is that it can result in irreversible organ damage. Jen, maybe you can share with us a little bit about your diagnosis and how the delay in diagnosis may have impacted your lifestyle.
Yeah, I hear this from my fellow patients a lot. Many of us can have very, very long delays, often a number of years. I had a lot of symptoms in the beginning that were, as you said, nonspecific, like sinusitis, adult onset asthma, lung problems and congestion. And it was kind of insidious and gradually building over time. So it was really hard to connect the dots. And then some strange rashes occurred. Nobody connected that. I had vocal cord paresis. It was idiopathic, they said. And then I started getting a lot of tingling and numbness and the peripheral neuropathy. And it wasn't until all those things kind of coalesced, along with the eosinophilia in my blood, that we were able to finally make the connection. But you can see all of those things happening separately. It was really hard to connect the pieces together.
So who made the diagnosis? Was it your primary care, or were you going from specialist to specialist trying to hunt down what was going on with each of these patients, with each of these symptoms that was occurring?
I had an asthma doc, and my asthma just seemed to not be well controlled. And they diagnosed a bronchiectasis on a CT scan. So then I went to a specialty center for the lung manifestations. And when they started running blood work, we found the eosinophilia. So those things led me then to the rheumatologist because of the neuropathy and trying to connect all those pieces. So I was seeing one doc for a long time, but it wasn't until I started having the more advanced symptoms and going to a number of specialists that we finally were able to hone in on the EGPA.
Yeah, that's not an uncommon story. Many patients go undiagnosed for a long time. And oftentimes that's because when we think about how to diagnose this disease, it's because it manifests in so many different organ systems that no single specialist may identify and connect the dots. You have to try to put the pieces of the puzzle together. The other thing is, not only can this disease present in many different organ systems, whether it's the sinuses or the lungs or the heart or the kidneys or the GI tract, or with neuropathy or with rash, but also doctors often look at blood tests, and there isn't any single lab test that can really help with the diagnosis other than perhaps recognizing eosinophilia. And eosinophils in general can often go undetected in many patients. A lot of physicians don't even look at the differential, and patients can be walking around with 1,000 or 2,000 eosinophils and may not be recognized as having a high eosinophil count that could be causing patients symptoms. So it's generally incumbent upon the patients to really move beyond their primary care doctors and look at some specialists who have the ability to recognize EGPA. But oftentimes even the specialists don't recognize EGPA. Can you share a little bit about that, your experience in that regard, beyond just, eventually finding the rheumatologist? How frustrating was that from your perspective?
Yeah, it's incredibly frustrating for patients when you go and see the doctor and you feel like maybe they were Googling before they came in to see you. But in terms of getting a diagnosis, it really takes listening, for the doctor to listen and ask questions, and for patients to be persistent and being able to continue to ask what's going on with me. Many of us may have been sick for years and years, and you just start feeling worse and worse, like the fatigue and the pain and those things. And it's hard for someone to really take you seriously and listen closely. So I always talk to my fellow patients, and we tried to give ourselves, self-confidence to be able to keep pursuing answers.
It's so important to seek out expertise because there are doctors who do have some expertise in the areas that might be affecting you specifically. I think one of the other challenges is the fact that there are some overt symptoms that become manifest that can be seen on physical exam or on lab findings or on imaging. And those can sometimes be the most bothersome symptoms. But a lot of the other symptoms really are a bit more hidden, they're a bit more subtle. And that can be very challenging for the patient as well, whether it's fatigue or brain fog or sleep disturbances, which a lot of patients experience. We've seen that with the rise of long COVID. We've seen that with chronic fatigue syndrome. And a lot of times those symptoms get dismissed. So it's important to try to evaluate what those symptoms are in the context of other ways that the patient can present. And sometimes these things can get attributed to a different disease, or patients can be misdiagnosed. A lot of times as well, there can be new symptoms that are still mild in their severity, and those as well may not necessarily be focused upon. And so it's important to evaluate those things as well. And sometimes patients just adapt. They accept what's going on. They say, well, I've been working really hard, so of course I'm fatigued. And they think it's normal that they might be sleeping 12, 14 hours a day and being exhausted all of the time. Jen, tell us a little bit about your experience with some of these more subtle symptoms and some of these constitutional symptoms, if you will.
Yeah, exactly like you said, Dr. Wexler. It can happen very subtly in the beginning, and then you write it off. You say, oh, I'm getting older, or I haven't been exercising, or I'm working too hard, or not sleeping very well. And we're incredibly able to adapt to all kinds of things. And it takes a while to be able to see even what's happening to yourself. I mean, I have a neuroscience background, and I miss my peripheral neuropathy. I fell a few times. I had numbness and tingling. It's easy to just say, oh, you're sleeping funny, or it's that, shoulder pain I used to have, or something like that. And I hadn't realized that I had lost feeling in my hands and feet. And I wasn't able to connect all those things together for quite some time until the light bulb went off. And I think that most patients have stories just like this because we all tend to adapt.
Yeah, and I can see, I see with many of my patients with EGPA and with other diseases, how these symptoms really affect your daily life and how disruptive they can be. And people don't even recognize the impact that the disease is having, not just on their physical health, but also on top of their mental health, their physical functioning, their social life, their interaction with families, with friends, and also how it can affect women. All of these factors really can be impacted by a single disease. And then you get to the physical manifestations, whether it's the neuropathy or the shortness of breath or the weakness that can occur in many of these patients, and how disruptive that can be. All of this leads to a sense of hopelessness oftentimes and a negative future health outlook. Can you describe sort of what your perception was, what your fears were in terms of dealing with this from a mental health perspective, from a mood perspective, and what your overall health outlook was when these things affected you?
Well, I would say it was incredibly isolating. Nobody expects to be diagnosed with a rare and potentially fatal and organ damaging disease. And then it kind of comes out of nowhere. And of course, you're not feeling very well. So progressively feeling more and more fatigue and pain and wondering what's going on. Even with my background, it was really a struggle for me to feel heard. And I was fighting very hard to get to the point of the diagnosis. If I could just find out what was wrong. But of course, now being on the other side of that, I realized that's just the first step of the journey, and there's quite a way to go. And being able to find the support that you need, not just from your doctors, but obviously from your family and other support of other patients, has been really, really tremendously helpful to me and to others.
Yeah, no, it's so important to have the support systems in place, and really try to get to answers about what's causing your symptoms. Now, one of the less obvious constitutional symptoms in EGPA is fatigue, and this gets reported by many patients as one of the key reasons for poor quality of life. I think we need, as physicians, to really try to differentiate between feeling tired, which I am all the time, and being fatigued, which really causes a burden on patients' quality of life. And I think we need to really review what patients know about fatigue and why it occurs in a variety of different systemic illnesses, but particularly in EGPA, because oftentimes patients come in with fatigue and it gets misattributed to depression, chronic fatigue syndrome, or fibromyalgia. But I think if we can identify fatigue earlier on as a key component, as a key constitutional symptom in our patients, then we might be able to have an impact in terms of coming to diagnosis sooner and impacting patients' quality of life. Jen, tell us a little bit about how fatigue played a role in your quality of life and how it became manifest, and maybe some of your experiences in that regard.
Yeah, the fatigue can be really overwhelming, and it, as you said, it's a constitutional symptom, so it's there in the background. Being able to distinguish between being tired and fatigued, as you said, is so important. When the fatigue is not relieved by sleep, it's not relieved by resting. It's just there. It's like it's like you're slogging through quicksand, or like you have a low battery and you're just trying to go and you can't. And the amount of energy it takes just to do everyday things like take a shower and make yourself something to eat can really, really be so overwhelming, especially if you don't understand why it's happening, or people say, oh, just rest, or, maybe you're just tired and you need to sleep more, but sleep doesn't help. And so many patients deal with the fatigue, every one of us in our own way. And many of the treatments that we get don't seem to help the fatigue. And I think this is one of the biggest unmet areas, right? Being able to understand that we don't have a lot of good ways to treat fatigue right now, and we need to do a lot more research to understand that.
Yeah, I think I've had a number of patients who describe what they call loginess, or they are just incapacitated by their fatigue. They need to just lie down and stop whatever they're doing in the middle of the day in order to get through the day. Another manifestation that we see a lot, which I think is probably the most bothersome for many of our patients, because it's very clear when they develop a neuropathy. It's a very common part of EGPA. It's one of the key criteria in terms of identifying and developing a diagnosis of EGPA. And yet it often doesn't necessarily lead to a diagnosis early on. Patients can present with peripheral neuropathy, with occasionally some numbness or aching pain, and then they can become manifest as weakness as well, with loss of strength. People can trip, they can have a foot drop, they're often seen as being clumsy, and that can be a really important early sign of the manifestations of EGPA. And so you really need to develop targeted questions to avoid missing any neuropathy symptoms. One of the things that I tell other specialists is not to just focus on your own organ-specific entity, but you have to take a full body approach. You have to take a very detailed review of systems in terms of trying to identify all of these different features. I'm sure your asthma doctor was focused on the lungs and didn't necessarily say, well, tell me about your numbness or tingling. Tell us a little bit about your experience with neuropathy and how that affected your quality of life, Jen.
Yeah, for the neuropathy, as I said, I had this initially kind of tingling and burning sensation. I was having a lot of pain in my arm and my shoulder, and I had vocal cord paresis, and they were not connected with each other at all. I fell a few times, and again, these are the things that kind of happen on the side, but you don't go to the doctor when you have some numbness or something, or you kind of write it off and you say, I don't know what that is. During the course of early in my disease, I also developed some odd loss of feeling in my hands, and white or purple fingertips, and on my feet as well. But they didn't happen at the same time that, say, I had rashes. They kind of happened at different times. But I think that a lot of patients have incredible pain from the neuropathy, debilitating pain, and it's a very, very big impact on quality of life for us. Fortunately, the pain that I have from my neuropathy is not too intense, and I think that's because we're able to catch it relatively early. But many patients will have ongoing pain, and even when they're in remission and on treatment, will continue with the pain, which has a profound impact on their quality of life.
Yeah, it can really impact their functional status. They can't pick up objects, or if they can't walk well, it can have a huge impact. And I think it also causes significant mental health issues as well. It can be very depressing to have neuropathy, and you put that on top of all of the other symptoms. So let's talk briefly about some of the mental health considerations, which can be both due to the disease, but also due to the treatment. Corticosteroids in and of themselves, which are used to treat this disease, can often be associated with depression and anxiety. And those, in addition to the underlying disease, can play a significant impact on patients' quality of life, and interacts in terms of causing some of the fatigue that's going on as well. What are some of the mental health factors that played a role in your disease, and how did you deal with it?
Yeah, that's a great question. Well, I mean, you mentioned the medications by themselves, right? The prednisone alone can be quite an intense experience, and I don't think we prepare patients very well. Send them off with high dose of prednisone, and good luck. Good luck with that. So I think we spend a lot of time in the patient community supporting each other in this regard, and trying to make sure that we're listening, right? Sometimes it's just listening. Even if you don't have an answer for what's going on or you don't have a treatment, to be able to acknowledge that what we're feeling is real is so important, because if no one is acknowledging how you feel, then they're essentially saying that it's not really happening to you or it's not important. And it's hard to get help for that. And it's hard to ask questions and feel supported. I was pretty fortunate. My response to prednisone has been pretty good. And as I said, I was caught pretty early in my disease. But you never know when you're going to hit a roadblock with the mental health aspect. You think you're getting better and you have a flare again. I've had 9 flares since I was diagnosed 8 years ago. Most of that happened in the first few years when we were trying different combinations of medication. But each time you feel like a setback and you have to figure out how to get back up and move forward again. But you get there, and you do.
It's such an important piece of this overall patient management program. You need to have a good specialist who's going to help you address some of those mental health needs, on top of your other providers who may not necessarily feel comfortable in dealing with a lot of those components. But I think recognizing that this is an issue, both due to the disease as well as due to the medications that we put patients on. So who managed your disease? A lot of times patients require a variety of different specialists because this disease affects so many different organs, from the heart to the lungs to the nerves to the joints to the kidneys to the skin. So who helps manage your disease?
Well, I've got lots of ologists that I see, right? But my rheumatologist, that's kind of what I call my head coach. And I'm the quarterback. So the head coach and I, we can talk strategy and call the plays. And then I'm the one who has to get on the field and execute them. And I'm the one who takes the hits and then has to get back up and go back in again. But it's me and my rheumatologist, and we work very closely together, and we manage the other folks, like the special teams, all the other ologists. I think that's really important, that patients know who their go-to person is and who's going to be their head coach so they can partner together.
It's so important to have a decision-making team, and it's so important for there to be good communication between all of the different specialists, because everyone has a bit of a different expertise and different experiences that can help us manage our patients best in all the different manifestations that are occurring in our patients. So let's move on to talk about treatment planning and how we can use shared decision-making between the physician and the patient to try to arrive at a good plan that individualizes the care for each patient. We know that EGPA is such a rare disease, and even experts will have difficulty keeping up with the latest recommendations. So I think it's incumbent upon patients to make sure that they've got good advocacy and see someone who's an expert in managing EGPA. So Jen, it sounds like you had a rheumatologist that you found who can be your coach, who can help you as the quarterback manage through these different diseases. Tell us about some of the different decisions that you've had to make in working with your coach, your expert rheumatologist, in terms of deciding which treatment was best for you.
Yeah, so first you need an expert, as you said, someone who understands EGPA and ideally has many patients with EGPA. It's such a rare disease that you probably need to go to a center of excellence or a specialty group that sees more than just you. So that was really important to me. And I was able to partner with an expert who listened to me And, each patient is unique. We all have different challenges when selecting meds and how we're going to respond to meds. And it is a trial and error process. There might be a script to start off with, induction with prednisone and then moving on to a DMARD or something like that. In my case, the first few didn't work. So it was trial and error for us. And as I worked very closely with my rheumatologist, we got to know each other very well. We were able to have those discussions and make those decisions together each step of the way. And that's why I think we were able to find a combination of medication that's been working for me. And that was really, really a success, I think.
It's important to really identify your goals of care, because sometimes there can be a disconnect between what the physician perceives as the goals and what you as the patient perceives. So I think it's important to have that discussion as part of your shared decision-making, recognizing that there might be sometimes where the physician wants to target a specific eosinophil count, for instance, versus you may want to target a specific steroid dose that you don't want to have an over significant number of side effects. So we need to evaluate all these things in that type of context. We need to arrive at decisions together as a team. And it needs to be really a team approach, being together very closely. We need to think about what are all the different treatment options. Yes, it might be one option that's good for one patient and another option that's good for another patient. But I think it's important to have the voice of the patient in that decision-making to assess everyone's values and everyone's preferences in order to reach the treatment decision that's appropriate for the patient. And then it's really important to evaluate how the treatment approach worked. And you need to do some constant monitoring. So let's talk a little bit about that, about some of the realistic expectations for treating EGPA. I view that there's this ideal component. We want to give the right drug to the right patient at the right time and achieve complete disease remission. However, how does that compare with the reality of how we often achieve outcomes in our patients? Jen, what's been your perspective about the reality and some of the challenges you faced as we try to treat EGPA in you and in other patients?
Yeah, so in the beginning of my journey, I was very focused on the diagnosis. And I thought, okay, now I've got the diagnosis of what's been going on with me. We're going to fix it, right? Well, not so fast. It's a process and it takes a long time. And all of these meds have their own side effects and toxicity, et cetera. And it really is a balance. So I thought the hard part was getting to the diagnosis. But for me, the hard part was trying to get to remission. And it took me several years and a combination of different medications to try until I was able to get there. And it is a balance. I'm still on several medications in order to prevent me from having a flare. And I'm indefinitely on these medications. These medications are toxic and they all have their side effects, prednisone included. I'm still on prednisone every day, and I have been for 8 years with no end in sight. So being able to understand how to live with vasculitis, how to live with EGPA, and how to balance the toxicity and the side effects with the risks for a recurrence of EGPA they're hard conversations to have. And these are long-term conversations too. It's not something that you can just talk about for a few minutes in the office visit every 3 months and then say, okay, yeah, see you in another 3 months. So it's really hard to have those discussions with the doctor in the short period of time because we have so much to cover. But they are really, really important, especially to my quality of life and for how I'm going to do in the future.
I agree. I think the key word they use is balance. And we have to balance the benefits of the therapies with the risk of toxicity. We have to balance our goals of trying to achieve full remission on therapy with some of the challenges and complications of treatment. So we need to think about all these things. You mentioned corticosteroids and what some of the issues are. And traditionally, for EGPA and other vascular disease, the management has really been steroids, and more steroids. And they're great at controlling some of the inflammation and improving symptoms. But first of all, they're not effective in all patients. Many patients need to go up on the dosing. They need to try additional therapies. And they can have difficulty tapering or discontinuing the corticosteroids. But I think the most challenging issue for my patients is a high risk of adverse events that occurs in patients. The weight gain, the depression that we've talked about, and then other physical manifestations, just simple things like bruising that occurs, not to mention all of the long-term consequences of corticosteroids, from cataracts and glaucoma to hypertension to osteoporosis. What sort of side effects did you experience as part of your treatment with corticosteroids?
Yeah, well, I have cataracts. I go for my DEXA. I've been trying to keep my bone density up. I had some weight gain. I had headaches. I also, I think, had trouble sleeping and, the usual stuff. Probably the biggest change for me was the Cushingoid syndromes and the moon face and all that. I felt like an alien. I didn't look like myself. I still don't look like I did before I started taking prednisone. It's probably the biggest thing, prednisone, that patients talk about. How do we try to minimize the prednisone? And many of these changes that happen to us might not seem so critical to the doctor, but they're such an impact on patient quality of life and our sense of well-being and our sense of who we are.
I absolutely agree. I think that we need to be, as physicians, cognizant of all of these side effects and the impact it plays on the quality of life of our patients. But I think one of the things that's most exciting to me is we're in a little bit of a new era now. And over the last several years, we've had development of new therapies that can help us minimize toxicity of some of the corticosteroids, that can help us get a little bit closer to remission in many of our patients. The most exciting thing from an EGPA perspective, from the way I think about things, is really the development of some of the biologic therapies, including the anti-IL-5 therapies that have emerged. Mepolizumab is a monoclonal antibody that targets interleukin-5. It was approved in 2017 for the treatment of EGPA after it demonstrated significant efficacy in terms of reducing corticosteroid dosing, reducing relapses, and getting a subset of patients into remission. Now, it's not effective in all patients, not all drugs are, but really it's been a real game changer from my perspective in terms of management of EGPA. And oftentimes, one of the main questions that I get from patients who are newly diagnosed with EGPA is there something else? Is there something beyond corticosteroids? Jen, I don't know what therapies you received, whether you got an anti-IL-5 therapy or any of the other non-biologic therapies, but what are some of your experiences?
Yes, I'm on biologics, anti-IL-5, and it's been extremely helpful for me. I was able to reduce my prednisone dose by 50% after I started biologics. This is something that's extremely exciting for the patient community to be able to see options aside from the traditional DMARDs, and options that can help us to reduce the prednisone. It can make a huge impact on our quality of life.
Well, I'm thrilled to hear that, and it sounds like you're doing great, and I'm delighted that you're achieving some degree of success in managing your disease. So this has been a great discussion. I've been pleased to have Dr. Jennifer Gordon, who's a patient with EGPA. I think we've learned so much today. Let's review our SMART goals for this activity. We wanted to really review treatment plans and goals for disease management at each patient visit. We want to utilize systematic processes for evaluating patients for symptoms of EGPA. And importantly, we want to utilize shared decision-making when evaluating the need for ongoing corticosteroid treatment for our patients. So we hope you will view the other parts of our educational series on EGPA. Thank you again to Dr. Gordon for joining me today for our discussion. Take care, everybody. We hope to see you again next time.